This condition is make disaster and even anticoagulation. So this is a practical problem. How it can be dealt? Any idea? Any other panelists? Or what's your take on this case?
If any one of the panelists wants to take a question, General Nuri. Can you hear us now, Dr. Fahim? There is a question if you are here with us, or any other panelist would like to answer this question.
We can. I can just hear you now. So I didn't hear the question.
So the question is, in a setting like Pakistan, with thrombolytics being used in quite a lot of patients in the periphery, particularly where there's no primary PCI, and you find a STEMI, and people are given thrombolytics and eventually found to have SCAD when they have an angiogram. How do you deal with that? Because, I mean, you're talking about question mark heparin. And here are these patients who may get thrombolysis.
I don't think it's been systematically studied. I mean, intuitively and in theory, a patient with SCAD, when you give them thrombolytics, they're bound to not do well because it's going to worsen the hematoma, the bleeding into the vessel wall. But has it been systematically studied as to what happens to these patients? I honestly don't know, but I'm going to guess that it's difficult to study because SCAD at the end of the day is an uncommon condition, and then on top of it, it is often not recognized, and therefore we really don't know how many of those cases get thrombolytics. But yeah, I mean, those that make it to the cath lab eventually, you will just have to deal with whatever the aftermath of a thrombolytic therapy is. But in general, I would say that lytics will worsen the biology and pathophysiology of SCAD.
Yeah, I think that's an intuitive answer, right?
But let me add to this. That's absolutely a great question. So I think the treatment for SCAD is recognition, 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 recognition. Every time you go in a young female, and when I talk about young female, I'm talking about 50s and less. Of course, it can happen in older, it can happen even a lot younger. Go in a female and you inject and you're looking at all the other coronaries being very normal, and then one artery is blocked. Think SCAD, think SCAD, think SCAD. It is actually even more frequent than when we're recognizing, and more we're talking about not being recognized.
Yeah, great
and
comment.
Once you recognize it, then the next thing that there is, if you've got even a slight amount of flow, walk away. And I was just saying to Tariq, Shahab, and Fahim here, I frequently talk about taking my left hand and holding my right hand and turning away and walking away from a SCAD. The more you do, the worse it gets. If the most that you want to do is, if it's completely occluded, just do a small proba and walk away. Yeah. The whole discussion is recognition.
Great comment, Naeem. In the interest of time, I think let's move forward because Perwaiz Meraj has to leave for his talk on cardiogenic shock. He's Associate Professor in the Department of Cardiology at Hofstra Northwell Health School of Medicine. Dr. Perwaiz Meraj, over to you.
Thank you very much. I hope you can hear me. Can you all hear me in the hall?
Yeah, very well. Yes, thank you. Please go ahead.
Okay, great. Assalamu alaikum and belated Eid al-Mubarak to everybody in Pakistan. Thank you for the invite and the honor of being part of Pak Live. Since I was there back in 2018, this has grown to be a great program, and inshallah, hopefully one day I'll be able to come back live in person as well. So it's a pleasure to present this topic, support in shock, near and dear to me, and we'll start going through the slides. I have no disclosures. So I want to start with a case. I think it's important to discuss shock and how we manage shock and devices in shock by looking at different cases that we do. 68-year-old gentleman with hyperlipidemia who presented with 1 hour onset of substernal chest tightness. His family insisted on bringing him to the ER. He refused. He thought he was just having some indigestion. His EKG upon arriving to the ER was this. Now, in the context of a STEMI, this does not qualify as a classic STEMI. However, as we all know, whenever we see elevations and depressions the way we're looking at here, clearly there's a global amount of ischemia occurring here, and someone who, in the setting of shock, is quite concerning. These were his hemodynamics. His blood pressure was 70/30. His heart rate was 130. His respiratory rate was 40. He was sounding only 90% on a 100% non-rebreather face mask. We went in and did a quick EDP and a quick ventriculogram, and we can see here clearly EF is down. The EDP, like I said, was in the 40s, very elevated. You can see here he has an RCA that has some disease, but overall not significantly, closed. Apologize for the grainy picture, but I had to zoom in here just so you could see. This is a shot of the left main, and you can see here the left main is completely occluded. So this is not something that we see very often, but obviously the reason we don't see these cases very often is because most of these patients usually don't make it to our cath lab. The left main occlusion MIs are not common. And so what do? So do we call a surgeon? Do we start with opening up the vessel? Do we start with some kind of support? And if we choose support, what kind of support are there? Obviously, I'm talking to you from the United States, so we have obviously the plethora of support options, but understanding that the entire world is not so fortunate to have all these options available to them on the shelf for obvious reasons. These are the options that we have, and the last one is call for help, which I think is a reasonable option in any case that you have someone in extremis and shock. Probably it's always good to have all hands on deck because the person could have a cardiac arrest at any point in time. If you look at the National Cardiogenic Shock Initiative guidelines, this patient meets all the criteria for shock, such that the systolic blood pressure less than 90 for greater than 30 minutes on supportive measures, both from the original shock study, the IBP2 shock, and the culprit shock studies, as well as, like I said, the NCSI algorithm that's run by my friends Bill O'Neill and Barbara Basir, and obviously Cal is on the call as well, the group over there that really started this all. Even the danger shock trial in Europe that's currently ongoing really shows the same type of numbers. Obviously, we're looking for end organ perfusion, and at the time of someone presenting to the cath lab, not always aware of what their end organ perfusion issues are, but you can suffice to say that these patients are quite sick and extremis. We do confirmations, looking at right heart cath numbers, and we do prognostication by looking at the cardiac power output, the PAPI, and the lactate clearance. If you look at the SKY shock pyramid, SKY actually put this out many years ago and has updated it and actually put clinical correlations recently. You can see here the stages start at the lowest risk of A, of patients at risk, the beginning of shock B, the classic stage of cardiogenic shock C, deteriorating stages of D, and in E is extremis, and that's always not frequently in circulatory collapse. So this patient was definitely in D, moving towards E. So someone that we definitely need to move quickly and do something about. We all know that there are many ways to improve patient hemodynamics, but we're talking about how to use devices. But just I wanted to make clear is that not all devices are the same. Balloon pumps are not the same as a tandem heart device, are not the same as an ECMO device, and not the same as an LVAD or percutaneous LVAD like an Impella. They all function differently, they all work differently. They're all designed to help the hemodynamics, but they all do it in very different ways. One thing I want to remind everybody that I think this is important for the coronary perfusion flow. If you have someone with a mean arterial pressure and a low LV end diastolic pressure, if your mean arterial pressure is low, as in they're hypotensive, and their LV end diastolic pressure is high, as in their heart failure, acute decompensated heart failure, you can open a coronary vessel, but if you don't have any coronary perfusion pressure, opening the vessel is not going to do much for the patient because you're not going to really have any sustained flow. So really the key is to open the vessel, but really open the vessel in the setting of an improved hemodynamic setup. PV loops are important to understand what we do. I'm not going to go into too much detail. I'd rather discuss more of the case, but to suffice it to say that our goal is to try to decrease the total pressure volume area, to try to decrease the potential energy in the stroke volume and improve the stroke volume. We all know what happens in cardiogenic shock. The PV loops move to the right and the contractility curve comes down. And so what we're trying to do is we're trying to take care of the patient. We're trying to make sure that the patient can be done well. So we actually ended up getting femoral access in this patient, knowing how sick this patient was. Unfortunately, this person also had peripheral arterial disease. So we initially placed a balloon pump because it was the only device that was going to be supported by his peripheral vasculature. We then went ahead and opened up the left main with balloon angioplasty, but the patient's hemodynamics, as I said, never really improved. And so as a result, we had to start escalating care. I think this is the most important part, is not to wait till the person gets significantly worse, but to understand the hemodynamics, understand how things are not going in the right direction and not improving. And so we immediately went ahead and had to do some vascular work to improve the access site to be able to place an Impella. And so what we were able to do is at the same time as we opened the vessel, we were simultaneously working on the iliac artery disease. We stented it. We ended up putting the larger 14 French sheath impella sheaths in, and we escalated from a balloon pump to an impella. After the impella was placed, you can see here, we opened up all the vessels, we stented the LAD in the left main, ballooned up into circ, and we're able to restore essentially as close to TIMI 3 flow as you're going to get in a patient like this, but the patient was still quite ill, and the patient is still significantly sick, improving, but significantly sick. At this point, the patient is intubated, pressors have been started, both the advent of the impella and the initiation of the impella pressure requirements have gone down significantly. This is the final picture. You can still see here the flow is a little compromised, but that's mostly due to the plugging both of the distal vasculature as well as the elevated end-diastolic pressure. And I always show this picture at the end because I think when you take care of patients like this in shock, you always must have some invasive hemodynamic measurements to be able to manage the patient. It would be virtually impossible to manage these patients by looking at their cuff pressures or particularly just an A-line pressure. Invasive hemodynamics is really the only way to truly manage the patient and to de-escalate or escalate care as necessary. So in the summary, really it's important to understand the hemodynamics. The invasive assessment and therapies are likely to improve. I firmly believe that you should support the patients prior to PCI. There's a lot of data out there that says even balloon pumps are better than nothing in the concept of supporting before PCI in shock. And I think it's important that we sort of move towards this. Really to change the conversation, I think a lot of times if that patient had not done better, we would have escalated to ECMO and we would have left the impella into ventral heart. And so something called ECPella here in the United States. And so it's more of a conversation of how do we use these devices together rather than being in camps that say I'm an impella user or I'm an ECMO user. I think that's less useful to the patient and it's more useful to understand where the hemodynamics really are for the patient's benefit. And it's really about the patient. Let's tailor the therapy to the patient, not just using this particular device because that's what we're used to. And like I said, call for help. I think if you're not comfortable with a certain device or you need ECMO here in the United States, a lot of times our cardiac surgeons are helpful to us in placing the ECMO and work with us as a team. And it's very important that we work with them as a team to try to improve our outcomes. One plug for anyone who's available in October later this year, we're going to be running Sky Shock. Please join us. It's a whole meeting just about shock, the practical aspects of it, and we're happy to invite anybody who wishes to come. Thank you very much for the opportunity to be here.
Thank you very much.
Can I
There's a comment,
ask
yeah,
a
from the
question?
panel.
Dr. Perwaiz, it's Dr. Suhail. It's a great talk, great save. Again, it looks great when you see that patient dying with cardiogenic shock and you putting a stent and saving his life.